Afternoon, everyone. Since it's noon, we can start. For those that don't know me, my name is Shruti. I'm one of the second year nephrology fellows. Today, I'm going to talk about complements in nephrology. How did I pick this topic? I was trying to decide what topic to speak on, and I was talking to my husband. He was like, "Why don't you talk about complements?" And I was like, "Absolutely not." So that's something that I do not like hearing because every time I hear a compliment, I just run in the opposite direction. It freaks me out. I remember Dr. Shah offered me a case for case conference for C3G, and I was like, "No, Dr. Shah, give me something easy. I can't do it." But then I was thinking, and I remember Dr. Lucci saying, you either pick a topic you know a lot about and you just tell everybody what you know, or you pick something you just don't know anything about, learn about it. So I thought maybe I can learn. Hopefully, this is useful, at least to our fellows. The attendees probably know everything I'm going to speak. So moving on. Oh, well. Okay. Well, I don't have any disclosures. My disclaimer, just like Isa and Angel, is that I did use AI. Open evidence was really helpful in gathering information, understanding concepts, and Google Gemini was a good resource to form all these beautiful images. I'm going to talk about just like the history, a little bit about the pathophys of the common diseases on which we have recent landmark trials, a little bit about safety profile and the gen. So what is complement system? As we know, it's a key component of our innate immunity. We know it protects us against pathogens, maintains homeostasis, has more than 60 soluble and cell surface proteins. Most of them are present in blood and serum or interstitial fluid. They remain inactive until there's a trigger which sort of triggers the whole cascade to go on. Looking back at the history, it was first discovered in 1890 when Jules Bardet actually found that there was this heat-labile component present in serum that, along with antibodies, was actually helping in getting rid of all these pathogenic cells. However, he did notice that when he heated the serum, it lost the ability to get rid of the pathogenic bacteria, thus realizing that there's another component that's present in serum, which he called the alexin. But later on, Paul Ehrlich came by and he said, no, we're going to call it complements because of the way it works and, complements the immune system. Then from 1890 to 1970, there was discovery of many different complements, receptors, proteins, their function, all of that was studied. In the 1980s, they came up with these receptors like CR1, CR2. Then later on, they also developed these complement deficient mice, which were deficient C3 and CFP. And then in 2000s, they learned the importance of this in neurodegeneration, TBI, and we're still developing new complements every day. As we know, in all these decades since it was first discovered, complements are an unchecked cascade. We know that they're a perpetrator of glomerular injury. They're always present. They're causing injury. We've been silencing them by silencing the whole immune system with the help of steroids, MMF, but we never really had targeted breaks until recently. Especially in 2024, 2025, we saw the first time that they had a first FDA-approved drug for C3G. And in the last 4 or 5 years, we've seen a couple of drugs that were recently studied that are now targeting specific components of the complement system versus the whole immune system in general. Let's look at this young man who came in with fatigue. He came in with peripheral edema, puffiness of his face, swollen feet, the usual cola-colored urine. His urine microscopy showed dysmorphic RBCs. He had a recent URI that he mentioned. We biopsied him. We saw C3GN. Now, the important question is, back in 2020, what were his options if we had a patient like this? Versus now in 2026, what are our options? I think we can answer this towards the end of the presentation, but it's an important question, which is what leads to this whole presentation. So before that, let's understand how do we go from antigen to complement. One of the ways is when the antigen is present in the body, then in the form of pathogenic bacteria or cells, it activates the B cells or plasma cells to go and form antibody against it. When this binding happens and there's immune complex formation, it exposes the C1 complex region in the Fc portion of the antibody, which then goes and helps activation of the inactive C4 and C2, leading to the downstream cascade of the complement system, which I'll talk in the next slide about. So complement system in general works through 3 pathways that we know of: the classical, the lectin, and the alternate pathway. The classical pathway is basically what I just explained, where you need an antigen antibody complex to trigger the immune system, the C4, C2, which then goes downstream and then comes the C3 convertase, and then that's where the three pathways actually converge on. The lectin pathway is a little different where it doesn't need an antigen antibody complex, but more so there's carbohydrates present on the surface of these antigens or pathogenic cells, which are identified based on a pattern recognition way by these complement systems. They then go and bind to them, and later on it just sets the whole cascade where they again lead to C3 convertase. The alternate pathway is a little different, which is constantly active with a takeover mechanism. It's low active. The C3 convertase or the C3, when it hydrolyzes, it sort of sets that into motion. However, if any of the other two pathways are triggered, that also sort of stimulates the alternate pathway, and then there's an amplification loop, which leads to this just going on. The C3 convertase then works on C3, breaks down into C3A and B. The C3A goes and primes more neutrophils. It's a very good anaphylotoxin. Basically, it's recruiting neutrophils and causing local inflammation. The C3B, on the other hand, works and activates a C5 convertase, which then breaks down again C5 to C5A and B. C5A, again like C3A, is an anaphylotoxin, but much more potent and stronger, causing local inflammation. C5B, on the other hand, goes down and activates a terminal complement, which is the C5B to 9 pathway. It also goes and binds to the cells, the C3B and the C5B, and basically presents it to the macrophages, being like, hey, destroy this cell. The MAC, how it works, it causes pores on these target cells and then causes lysis, thus causing destruction of those cells. This is a basic footprint of how complements work. Now, as nephrologists, our question is, why our organ? Why the kidney? As we know, the kidney is a very high pressure, high flow system. It gets 20% of the cardiac output, a large amount of blood going there. So every time there's complements that are activated in the blood, obviously there's a lot going to the kidney and getting filtered. Because of how high the blood pressure is within the kidney itself, it filters a lot of these molecules and activated fragments into the glomerulus. And based on the structure of the glomerulus, the GPM membrane is such that these weakly positively charged complements then go and bind to certain areas and receptors on the basement membrane. Thus, and then there's just local activation and inflammation, the whole cascade goes on. Now, complement-mediated disorders in the kidney is actually a whole spectrum. On the left, as you see, there's 3 of them that are mainly where complement is the primary driver of the disease, which is atypical HUS, C3G, and primary immune complex and PGN. On the extreme right are more multifactorial diseases, which have many other mechanisms, but complements do play a role in these diseases. And in between is the ANCA-associated vasculitis, the lupus, IgA, some of which I'll talk about today. I'm going to talk about the disorder, a little bit about the pathogens and the recent trial associated with them. Starting with atypical HUS, it's a rare life-threatening TMA, which is caused by uncontrolled activation of the complement pathway. There's this factor H, which is actually responsible for keeping the alternate pathway in check. In this, there can be genetic predispositions or autoantibodies to this factor H, because of which the checkpoint is lost, and now there's like just amplification of the alternate pathway. So it works with 2-hit hypothesis, where the first hit is the genetic predisposition. Patients have either antibodies or mutations. And the second hit is when there's a trigger like an infection, pregnancy, any other stressors. So basically, this is just a good diagram where the first hit, the second hit, and then there's just activation of the C3. Again, everything comes down to C3 convertase going down, leading to the MAC, anaphylotoxin, and local injury in the endothelial cells, forming the microthrombi, and thus causing the 3 things, the MAHA, the thrombocytopenia, and AKI. So they were like, okay, we need to find something that targets this. And they came up with a drug that targets C5. So eculizumab is basically a humanized monoclonal antibody that binds to C5 and blocks its cleavage to C5A and C5B. And as I spoke, C5A is the potent anaphylotoxin, and B is what drives the MAC. So now you block that, you're going to block the downstream effect. This drug, to get approved for treating atypical HUS, actually required at least 4 of the major trials that they looked back at. The first 3 were mostly adults, or at least not adults, but adolescents and adults, because the first one was more than 12 years of age. They either require the first study actually required, it was mostly acute progressive TMA, where they needed at least 4 sessions of plasma exchange or infusion in the prior week, a good GFR of at least 60, and they looked at change in platelets and hematological normalization like LDH and your counts. In the trial 2, they looked at more chronic atypical HUS, and those were, again, these were all like small cohorts, like 17, 20 patients. Here, they required more than 1 session of plasma exchange, a median of 48 months from the diagnosis. And again, they looked at TMA-free event for at least 12 weeks and hematological normalization. The third was a little bigger with 41 patients, similar endpoints with complete TMA response and less than 20% increase in the serum creatinine and LDH normalization. Trial 4 was actually more of pediatric population between 5 months to 17 years. And this had 22 patients in it, again, similar endpoints. So total of all these trials, there are at least 100 patients that were looked at. Dosing in the adults was 900 milligrams IV weekly for 4 weeks, followed by 1,200 milligrams in the 5th week, and then Q2 weeks, 1,200. In the pediatric, they actually dosed it based on the weight of the patient. Exclusions were ADMTS 13 less than 5%, other typical HUS caused from like STEC or prior use of eculizumab. And they treated these patients for 62 to 64 weeks. The only downside is there was no randomized control trials. They just looked at, it was more like, I guess, retrospective. Prospective, sorry. And then this is what led to the FDA approval, like I mentioned. Now, another drug that was similar to eculizumab that was approved in 2019, a few years later, was the revalizumab. This is a long-acting monoclonal anti-C5 antibody that is similar to the eculizumab. They actually engineered this from the eculizumab where they changed 4 amino acids and substituted it, and then this came up with this drug. The benefit of this was the dosing. The maintenance dosing was actually 4 to 8 weeks as compared to eculizumab, which was Q2 weeks. So longer duration where they, less frequent medication, I guess. The FDA approved this for adults and pediatrics more than 1 month of age in 2019. And the primary endpoint, again, was similar to the one in eculizumab, where they looked at complete TMA response at 26 weeks with platelet normalization, LDH normalization, and more than 25% improvement in the creatinine. Now, again, there was no head-to-head comparison trial with the eculizumab, but when they looked at all the studies, they saw that the TMA response was pretty comparable in the 2 drugs. The benefit in this was that the patients had less infusion burden because of how the frequency between the 2 doses. They saw that fewer patients discontinued dialysis in this group versus eculizumab, but they thought it was more like population difference in the 2 groups and drug-related. So practical pearl in the acute setting, despite revalizumab actually having a loading dose and maintenance dose, they still prefer eculizumab because during the acute phase, most of these patients get plasma infusion or exchange, and that wasn't studied with the revalizumab, is what they said. And also some of them have ADMTS 13 pending. So based on how the study was designed, they still prefer eculizumab in the acute settings, and then they say you can transition to revalizumab, and the transition is pretty safe. Once a patient is stable, you can transition it after the last 2 weeks after the last dose of eculizumab, you can give the revalizumab to them. There's still some ongoing studies. Iptacopan was, they looked at it, it's in the phase 3 trial. There's some case reports of its efficacy in C5 refractory atypical HUS, but not really like studies. It was just some case reports. And then some other drugs were the narsoplimab, which is investigated for TMA associated with atypical HUS, and the pegcetacoplan, which is a newer drug, not studied. Now, moving on to ANCA-associated vasculitis. This is somewhere in the middle of the spectrum that we talked about. Here, there's an antibody and a prime neutrophil. They bind together. That causes degradation of the neutrophil, releasing certain enzymes, which they then go on to activate the complement system. The main thing that drives this is the C5a, which I told you was the anaphylatoxin. That goes and binds to the C5a receptor, causes local tissue injury. And that also works towards priming more neutrophils. So their thought was, why don't we get something that, stops this? Let's find something that inhibits the receptor itself. And that's how they discovered the avocopan. And this was the study, the Advocate trial that came out in 2021, which was mainly for ANCA-associated vasculitis, where they used the drug avocopan. As we know, usually these patients have a huge steroid burden. So they were trying to find a drug that they could add or, substitute, maybe not substitute, but at least add to steroids to reduce the glucocorticoid toxicity exposure in these patients. This is orally administered, highly selective, binds to the C5a receptor and halts the whole neutrophil-driven destruction where it's priming of the neutrophils. The design of the study was a phase 3 randomized double-blinded trial. Both the groups actually got standard induction with rituximab or cyclophosphamide, more rituximab than the other. They used something called as a double dummy design. I didn't know what it was. So when I looked at it, it said that both the groups got 2 pills each. The avocopan group got the avocopan 30 milligrams for 52 weeks, and the other group got the placebo drug. In addition to that, the prednisone group, the other group also got prednisone taper because obviously they had ANCA, so they had to treat them too. So they got oral prednisone taper starting at 60 milligrams per day, and then they weaned it down by week 21 to 0. Though the one thing you have to know is the avocopan group also did get some steroids because one, they allowed patients when they were recruiting for this group, if they were up to 20 milligrams of prednisone dose, they were allowed to be in the avocopan group. And also they allowed the physicians to give them pulse dose steroids if they thought they were on flare and they needed something more. So overall, the exposure to steroids was, I think prednisone was around 1,500-ish in the avocopan group versus 3,600 in the prednisone group. So still a lower burden of glucocorticoid exposure. And the endpoint was, primary endpoint 1 was at week 26, where they looked at BVAS, which is a Birmingham Vasculitis Activity Score, of 0, meaning no vasculitis, like evidence of vasculitis. And they saw that avocopan was non-inferior, so they were kind of the same in regards to the first endpoint. Then they looked at week 52, where they again had a primary endpoint, where they basically had to meet criteria of endpoint 1, meaning at 26 weeks, they had met the criteria. Plus, they meet the same criteria at week 52, and they didn't have any relapse between week 26 and 52. So these were all the 3 that they had to meet the primary endpoint 2. And in that group, they actually saw avocopan was superior to the prednisone. Now, we have to remember that they did taper the prednisone off by week 21, and this was much later on. So they were not really on that much of prednisone at that point. They also saw at some other endpoints like the increase in the GFR, and the avocopan group was actually a little better than the prednisone group. They actually saw this benefit more in patients with lower GFR, less than 30. Obviously, the glucocorticoid toxicity index was lower because of how much they got, and serious adverse events were comparable. So even the FDA approval, when you look at it, it says that this is approved in combination with standard therapy, including steroids. So they've not just said you can substitute steroids because of how they did the study. They also, I forgot to mention the risk of recurrence. So they looked at that as well, and this was much lower in the avocopan group as compared to the prednisone group, again, despite having lower exposure to steroids. Now, moving on to IgA nephropathy. I mentioned this because we did the journal club last year with the avocopan, but this is something that is also it is again in the middle of the spectrum, driven by complement. It's an autoimmune condition where there's abnormal IgA1 antibodies that are formed in the gut mucosa that form immune complex and build up in the mesangium, thus triggering the complement cascade. It's a weak activator of the classical pathway, but does activate both the alternate and the lectin pathway. This is a pretty busy slide, but what we need to know in the first part is that it works with 4-hit hypothesis. Everything Gemini really works.
We just needed one more prompt in it. Please decongest the slide.
I tried, and this is what I ended up with.
Oh, this is scratching to cloud.
They take away important things, so I guess I need to do better with it.
I'm so sorry. This is not the discussion. But did you have to give all the details, or you could just tell it that give me a slide on that?
Some details, like what you need in the slide, and then it'll give you obviously, yeah. So the 4-hit hypothesis is basically the first hit is formation of these aberrant IgA1 antibodies in the mucosa. The second hit is when there's antibodies formed against these abnormally glycosylated IgA1. The third hit is when they form the complex, and the fourth hit is when they deposit the mesangial. And then that deposition sets the complement pathway into motion, mostly the lectin pathway, which again comes down to the C3 convertase and then the downstream effect that we mentioned earlier. The C3 convertase also works with factor B and factor D to amplify the alternate pathway, which is why they thought, let's find a drug that binds to factor B and maybe targeting that will break the loop again. That's how we came up with the APPLAUSE trial, where they tested the drug called iptacopan, which was an oral selective complement factor B inhibitor. Again, a phase 3 multi-center randomized double-blinded placebo-controlled trial. They did it over 450 patients who had biopsy-proven IgA, a UPCR more than 1, GFR more than 30, and were on optimized RAS blockade. Randomization was 1:1. They got 200 milligrams BID of iptacopan versus placebo for 24 months. And the endpoints, at 9 months, the first endpoint was changed in the 24-hour UPCR. And then again at 24 months was analyzed total eGFR slope, like did it stabilize the GFR. So looking at the primary endpoint at 9 months, pretty dramatic, as you can see, between the placebo and iptacopan, there was a significant improvement in the proteinuria. In fact, they saw it very early on, within the first 2 weeks, a dramatic improvement. It kept going on. And at 9 months, if you see, there's 38.3% reduction. With regards to kidney function, which was done at 24 months, they looked at the eGFR slope. And again, you can see the iptacopan group is better than the placebo group. The safety overall, adverse events between the two groups was 88%. So they did have, it ranged from like URIs, nasopharyngitis, even headache and diarrhea, all the way to like serious adverse events. And serious infections, which were slightly higher in the iptacopan group at 6.7% versus 2.1% in the other group. There was no deaths in either of the group. And the impact of this was that FDA actually accelerated the approval of this drug at the 9-month mark itself when they saw such improvement in the proteinuria. And then it was confirmed at 24 months when they finished it. Now moving on to the drug. This is one of the most talked about drug when we talk about complements, is C3 glomerulopathy. How did it come in, like how did it get recognized? So back in 1962, Berger and Gall actually looked under the electron microscopy and saw these dense deposits, which were ribbon-like. Just because of how they looked, they went ahead and called it the dense deposit disease. And it was called so up until 2007 when Service et al. Came by and he was like, wait, but this is what I see under electron microscopy in most cases, but then there are some where on immunofluorescence I see C3, but when I look at the electron microscopy, I don't see the dense deposits you were talking about. I actually see these granular cloud-like clusters, which is not the typical. And that's how they discovered another entity called C3GN. So at this point, we have the umbrella term called C3 glomerulopathy, which includes both the dense deposit disease and C3GN. Again, this is driven by genetic or acquired mutations, which cause defects in the alternate pathway, thus leading to C3 accumulation in the glomerulus and basement membrane, and then thus causing the downstream effect. Again, a rare form, which can lead to CKD. Regulators, and like I mentioned earlier, the factor H, which controls the alternate pathway, can get dysregulated. Or sometimes it just gets stabilized by an autoantibody like C3 nephrotic factor. Kidney being a bystander just has to bear the brunt of whatever is going on in the blood. Diagnostic, like I said, immunofluorescence will detect the C3 stain, the staining, but we need EM to differentiate between the two types. And why is it important clinically is because it has a much higher morbidity of 50% patients going to ESKD in the next 10 years, and a much higher risk of recurrence in kidney transplant patients, almost 80 to 90%. Pathophysiology, again, like I mentioned, factor H and factor I get there's uncontrolled, or they get dysregulated, defective, so don't work. They don't work in stabilizing this, so there's just the amplification that happens in the C3, thus leading to deposition. So again, the same drug, iptacopan, is what they studied for this as well, because it's acting against the C3, so it's, or the factor B, so it's helpful in the alternate pathway. I think I mentioned most of it, but in the phase 2 part of this study, they saw that there was significantly increased serum C3 in these patients, reduced C5b9 and serum AP activity, and also reduced urinary C5b9, thus leading to see the phase 3 trial, which also saw similar results in the APPEAR trial. So the APPEAR C3G is again a double-blinded placebo-controlled trial, which included 74 adults. Not a huge population, but the disease was rare to begin with. It confirmed these C3G depositions had to have an eGFR of more than 30 and proteinuria at least of 1 gram. The study looked at 35 hospitals across 18 countries, and the participants were randomized either to get iptacopan 200 BID again or placebo for 6 months, followed by 6-month open label period where all the patients actually got iptacopan to see what the benefit was, even like in the patients that didn't get it for the 6 months.
Do you know if they excluded monoclonal gammopathy?
I don't. I'm not sure.
I think it was one of the exclusion criteria, but the problem is they use just SPAP to exclude it. Sensitivity of SPAP is like less than 50%. So who knows how many are monoclonal gammopathy in it.
Which requires a different treatment. So the primary endpoint at 6 months was reduction of the proteinuria, which they saw again, pretty good reduction. And this was sustained at 12 and 24 months in the open label period, where the patients that were switched or the ones that were in the placebo group, they also saw similar. So if you look at that curve, the top is a placebo, the one in the bottom is the iptacopan, and you see the improvement in the first 6 months. And then when you see the second part, even the placebo group does come down. So you see benefit, and it does pretty much tell you that it's a good drug. Some of the secondary endpoints were eGFR stabilization. The patients, they looked at the eGFR overall and they saw that it stabilized and the downtrend was not as prominent as before. They also had protocol biopsies at 6 months in some patients, and they saw reduced C3 deposition. The histological score, activity score was much improved, and serum C3 levels were also increased.
Was the GFR change statistically significant at 6 months?
I don't think it was, because
I mean, there's a trend.
I think when they did the second, like in this graph, they did say it was like 0.001. So I think it was.
So the decline is stopped, the decline stopped basically, right?
Yeah. After, I guess.
Yeah, I'm talking about this. Top is your control. I'm looking at the control versus placebo versus the drug. At 6 months, there is a standard deviation at 6 months. Oh, maybe I don't know. I just need to know the number, I guess. Just curious. When there's 30% reduction in proteinuria, so it's
Right. Yeah, no, I
great reduction.
It's almost by 27, you went down to 1, right?
Yeah. So that was before and then that was after. But I can look into that and let you know. With regards to safety profile, again, well tolerated, no deaths, no discontinuation, and most importantly, no meningococcal infections, which is important because the terminal pathway is what protects us against that. So we have to look at that. Clinical impact led to the drug being approved for targeted therapy against CP3. Now, the most recent trial, the Valiant trial, which was with a new drug called pegcetacoplan, which was a targeted C3 inhibitor, so not factor B, but C3 itself, and also C3b, thus halting both the complement-mediated pathway and the downstream terminal complement pathway. This again was a phase 3 double-blinded placebo-controlled trial, which looked at pegcetacoplan and C3G and primary immune complex membranoproliferative GN. This got published in NEJM in December of 2025, so pretty recent. Was done in 122 countries, 122 centers in 19 countries. Included adolescents and adults, mostly adolescents. I think the mean age was around 26. Patients with both C3G and primary ICM, and also included native and post-transplant recurrence patients. This randomization was again 1:1, stratified based on transplant status, baseline biopsy availability. The primary endpoint was proteinuria reduction at week 26. So they saw that there was a statistically significant 68.1% relative reduction in the proteinuria. as compared to placebo, which is pretty dramatic. They looked at it again at 52 weeks, where it was an open label extension data, where I guess more patients were allowed to get their drug, and 1/3 of the treated patients achieved complete remission, meaning that UPCR went down to less than 0.5, which is pretty good. They also looked at EGFR stabilization. Again, that was a pretty meaningful difference of 6.3. And the p-value was 0.03 on that one. They also did protocol biopsies in this study as well at 6 months, and that showed a remarkable 71% pegcetacoplan treated patients actually had 0 C3 staining. So that says something. It actually demonstrated complete clearance in these patients. Now, not all patients were biopsied, but the ones that they did, they saw this. This just shows the endpoint, like subgroup analysis and the improvement in the proteinuria reduction in the placebo group versus the study group.
Even if I ask one question, I keep seeing these immune-mediated glomerular disease, and you keep on referring to proteinuria reduction. Has FDA accepted that for definition of an active immune-mediated glomerular disease hard outcome defining surrogate? I know that it has been approved for chronic metabolic disease, decrease in albuminuria or decrease in proteinuria. Please, my apologies, but I'm not aware that FDA has approved. I thought the criteria still were complete, partial, and no response. Am I mistaken somewhere?
So you just mentioned for IgA, they approved patient on
Yeah,
proteinuria.
proteinuria. That was
FDA.
9 months. Yeah.
They put this presentation, both of these.
Looks
Yeah.
like it. I don't know for sure.
So from
Because
what
for
I
metabolic disease, there was a position paper from FDA and NKF, but I'm not sure whether I have seen similar for, I don't know. I'm
Well,
sorry. Go ahead.
These approvals are all conditional approvals right now. They're not gonna, none of these are gonna get full approval until they can prove EGFR protection.
Okay,
So that's why it's considered conditional approval.
I see. So they've created like a
Yeah, they made that.
new
so that-
category for that.
Yeah, so that you have option to try it, obviously in conjunction with conversations with the patient. Because these are rare diseases with no other good options.
So this is like pending hard outcome benefit. They will do
Correct.
it. Oh, gotcha. Okay, sorry. Thanks. That makes sense.
All right. So this was just the image that they had, where you can see pretty much like, the C3 deposits are gone. I just wanted to put this image here. Now, the safety profile in this study, again, they looked at serious events, severe events. The serious events in the pegcetacoplan group were multiple infections, the COVID, influenza, and pneumonia. 6 patients had serious events. Obviously, there was overlap, so total number of serious events was more than the number of patients. So like one patient could have more than one serious event. In the other group, it was more kidney related, like acute renal failure, nephrotic syndrome, tubular interstitial nephritis. Overall, in the pegcetacoplan group, there was one patient that died actually from really bad COVID pneumonia. So can cause really bad infection. But no serious infections again with encapsulated bacteria that we worry about in these patients. And then during the subsequent 26-week period, open label period, they actually saw 2 more infections emerge. One in the native kidney with C3G, where they saw strep pneumonia, which was an encapsulated, and the other was the kidney transplant that got it was also getting immunosuppression at that point with this, and they saw that had herpes meningoencephalitis, so had to be discontinued from the study. These were just some of the things that I was trying to look at what the study lacked or what was the downside. One of it is that the mean age was pretty low. Like I think Dr. Shah mentioned it to me yesterday. I looked back into it. I was only 26 years, so pretty young patients. And when you have someone that's older, you could think about how does this apply to them. Also between the 2 groups, the UPCR was, if you see in the pegcetacoplan group, was much higher at 2.3 grams versus 1.8. So it's not really similar. The EGFR again was different, better in the placebo group, worse in the drug group. And the mean age again was lower. Also, some of the adolescents actually were allowed to be in the study without having a baseline biopsy, just based on like surrogate markers, low C3 nephritic factor, without actually having a biopsy proven disease. And later on, they may or may not, like, not all of them got biopsies, like I mentioned. So there were some things which were still lacking in this. And overall, I think the thing to note though is even if there was like more proteinuria in the pegcetacoplan group and worse GFR, they still showed better proteinuria reduction. So I think that tells something that it does work for proteinuria.
Do you know what was their baseline characteristic C5b29? Like how many of them had an elevated C5b29? In the group?
Specifically,
Because not all the patients have elevated
Right.
C5b29.
yeah, that's too deep of it. I don't think we'll know. But I can look at it.
I mean, in general, in TATMA,
Yeah.
we used to say that in TATMA literature,
Right.
the eculizumab data showed that eculizumab is more effective if baseline C5b29 is elevated. Among the patients who don't
Right.
have C5b29 elevated, eculizumab wasn't very effective. So I
Right.
wonder which group are we studying? Is it the
Ah.
patients who have C5b29 elevated or not?
That's
And that will also add into your decision making.
because then that tells you the MAC is activated or not. Okay.
Shruti,
Yes.
quick note. So when we talk about immunosuppressive medications and them causing infection, just for the for the learners here, I would rather say it in a way that they make it harder to clear serious infections, right? Because none of the immunosuppressants cause they cannot cause an infection by themselves.
Right.
And it's pretty obvious to the rest of us. But I think even sometimes publications really mix those up, right? We just can't clear it. Those patients can't clear those activities.
On that note, Shruti, do you know like the patients vaccinated or like preventable, like all
Yeah,
of these sort
yeah.
of vaccinated?
Yeah. Not COVID, but I can tell you about the vaccination towards the end. Quickly, I wanted to mention lupus as well, because we know lupus has a component of complement-mediated injury in it. Obviously, it's more downstream. There's antibodies which lead to the activation of initially the classical pathway, later on the lectin pathway and the alternate pathway as well. We know that sometimes complement deficiency, like C1q itself, is what drives the complement downwards, but deficiency of that itself is important for clearing the immune complexes which trigger this complement pathway. So that deficiency can lead to lupus. So it's like a paradox where it also causes the injury, but its deficiency can also trigger lupus in the first place. The pathway is activated is classical in the beginning and then later on alternate and lectin pathway. You see 40% of the patients actually have this C1q antibodies present. Right now, there's no complement inhibitor truly designed or like studied for treating this. There's some under investigation. Eculizumab, they saw there were some case reports against for like lupus-associated TMA, but no real studies for it. A key difference from the other complement-mediated like the IC-MPG and C3G is that since the effect is more downstream of the complement, the treatment is more targeted towards upstream by using CNIs or like MMF. And I guess the complement inhibitors would therefore be more adjunctive to what we're using for treating the underlying cause itself. These are some of the studies again, nothing's approved, they're still under investigation. One of the new entity that I just recently heard about from my husband, and then I thought Dr. Shah was also mentioning it, so I just thought I'd bring it up. I couldn't find a lot of data on it, but it's a newer form of DN, which was recently discovered where you see dominant C4D deposition on the biopsy with minimal or absent C3 and immunoglobulin deposits. Indicating there's isolated more like classical lectin pathway activation without the alternate pathway involvement. Biopsy, you see bright C4D deposits on immunofluorescence. It's negative for C3, IgG, IgA, IgM. When you do light microscopy, you see like an MPGN pattern on it, and then EM will show you subendothelial and mesangial deposits. The pathophys is basically dysregulation of the classical lectin pathway, not the alternate pathway like we see in C3. There's reported association with autoantibodies to this C4 or some genetic component, but I think they're still being studied because it's so new. I think the study that mentioned this was only like 3 patients that they've seen it so far. They also present with proteinuria, hematuria, and low C4, must be distinguished from C3 because as of now, the only treatment that they, at least those 3 patients got was more conservative, like reducing proteinuria, RAS blockade, controlling blood pressure, but not like complement-mediated therapy. Key takeaways like when you see bright C4D and no C3 or IG, maybe think about this condition. And the workup would be check C4, C3, CH50, and EH50. Also rule out monoclonal gammopathy. So just looking back at the evolution of studies, we had the dark ages where we only did RAS blockade, MMF. A lot of patients became LCA kidney disease. Then we had the C5 era with eculizumab, which revolutionized.
This was 4 years ago.
Then we had the anchorship with the advocate trial where we blocked the C5a receptor, but did not affect the MAC. So that's important. Then we had the factor B with the appear trial, massive reduction in proteinuria and C3G. And now we came up with a variant trial with the pegcetacoplan, which showed again clearance of C3 and massive reduction.
Who decided the word gold standard there?
I know, I was thinking about it. That was AI. I was trying to take it out and put it. I was like, this doesn't look appropriate, but it was hard.
Now AI biology our brain.
It conveniently didn't pay attention that none of them are actually examining progression to ESRD,
Right.
which is what your dark age.
We're still waiting. But going back to my vignette from the beginning, so I think in 2020, his options were more steroids, MMF, RAS blockade, supportive measures, versus now we at least have 2 drugs that FDA has approved, which is eptacopan, pegcetacoplan, and then eculizumab if you have TMA-like features.
Or we can do mass fix to find monoclonal protein.
Yes. And then just important things practically for us is the safety profile because these all except avocopan block the terminal pathway. So these are the terminal pathway, like I mentioned, is what helps us protect against encapsulated bacteria. So we have to remember that all these patients, like Dr. Uji was asking, need to be vaccinated against that. Their risk is almost 1,000 to 2,000 fold higher than normal population. So it's very important to vaccinate. But we have to remember that the vaccination is not 100% because different people react differently. They form different levels of antibodies. So they have to be told that any fever is an emergency and you have to go to the ER to get evaluated because this can be life-threatening. And then the vaccination. So except avocopan, all of the other 3, they recommend vaccinating with mandatory meningococcal vaccines, 2 types actually, A, C, W, Y, and Men-D because they're different strains, and pneumococcal vaccine and influenza vaccine. And they also recommend starting antibiotics before right at when they get the first dose of the complement. Now, so they need to get these vaccinations at least 2 weeks before they get the complement inhibitor. However, if it's an urgent indication, you really need to give it to them, then you vaccinate them and you can start their drug right away. And also give them the antibiotics. The antibiotics usually used are penicillin V or macrolides that they're recommending. A second layer of defense. Till they finish the complement inhibition, they need to be on antibiotics. Again, patients need to be educated. They should carry something they call as a safety card where they, like at least the ER physician, when they go in, they know they're on complement inhibition. And now some centers, they mentioned that they were starting something called safety passport where the ER gets notified about this patient's complement inhibition history, like being on those drugs. Importance of genetics. So genetic testing for CFS, CFI, C3, MCP is now used to guide active management. Some patients with high risk of gain of function mutation might actually need more lifelong therapy with this complement inhibitor, versus some where you can consider like weaning it down with once the proteinuria stabilizes. But again, it's patient dependent. I guess you have to see how the patient is and decide. In transplant planning, they mentioned that identify donors with similar genetic vulnerabilities. It's crucial because donor-derived factor H, which may not be present in the recipient, might actually affect the transplant outcomes. And then there's something called variants of uncertain significance that might be coming up in almost 30% of the panels. This may not identify specific mutations, but if it's present in like multiple family members, you might want to think that it might be pathogenic, causing, have an association with what's going on and discuss with the genetic counselor. Modern approach for testing. Earlier, C3 alone was tested. Now they recommend doing comprehensive complement panel. Mostly functional, looking at CH50 because C3 is only a protein that's present. But when you look at this panel, it tells you is the pathway actually the alternate or the classical pathway is that active. Looking at individual C3, C4, factor B, H tells us where the defect specifically is. And then looking at BB and C5B9 tells us is that actively going on right now. And then C3 nephrotic factor, which is one of the pathogens I mentioned earlier. Why C3 alone is not enough is because less than only 50% of the atypical H2S and C3G patients actually have low C3. That normal C3 does not really rule out the disease itself. So measuring protein level only and not the pathway may not be enough. Key takeaways, like there's a Mayo Clinic, I guess you can send like 9 things in that panel, which is the ones I highlighted, and C4D. They check for all of that, and that's more of a combined approach that's much higher. Or in atypical H2S, they saw that factor B with CH50 had a much higher specificity of almost 89%. And then knowing the C5B9, like Dr. Shah was mentioning, actually helps predict kidney outcomes when the C3 is normal. KDIGO 2024 actually endorses using the comprehensive complement path workup now versus just C3 alone. So bottom line, C3 alone may not be enough and we need to listen. And that is it. Oh God, I didn't tell you.
Questions?
No, but if anybody has questions that if I can't answer, I have a lot of attendings here who know a lot more.
Well, that was fantastic. Thank you very much. If people have questions, they will come to us.
Thank you.
Oh, 17.
And I think the information
Like or something. Yes, that's like.
Thank you.